So once again, I really want to thank Dr. Coleman, Dr. Parmar, and the organizing committee, because it really has been a wonderful meeting, and they're getting better every year. So, I mean, I'm really looking forward to next year. So I think, as you've heard from the first session, the optimal treatment for myeloma is starting to emerge, that there should be some form of frontline induction which includes an IMiD and a proteasome inhibitor. The role of consolidation with transplant, particularly now with induction therapies that can get response rates upwards 90% and even complete response rates in 40%, has to actually be re-explored. And I'm going to talk a little bit about the challenges if we think about that re-exploration. I'm going to talk about maintenance therapy, which I think has also now been established as a potential standard of care, although there are, as Dr. Joshua mentioned yesterday, it's still not 100% clear that everybody should get maintenance. But it is emerging that, particularly for patients who have high-risk disease and who have not achieved a complete response to induction and consolidation, this does improve disease control. And I won't talk about relapse, with the exception of mentioning the potential role of salvage transplantation. So in 2011 and 2012, I think the themes that we're starting to focus on is, one, reducing the burden of treatment. So, I mean, we're starting, Dr. Orlowski talked to us about double versus triple therapy. Can gene expression profiling, can risk assessment decide who needs a doublet versus who needs a triplet? Can you start with a doublet and then only use a triplet in the event of not having the response you want? And finally, although in North America, bortezomib, lenalidomide, dexamethasone is rapidly becoming the most commonly used induction, I think we need to recognize that there really are no randomized trials showing that this is the standard of care. We are still at the point where we have no clear guidance about how many cycles of induction are needed before we take a patient to stem cell transplant. And yesterday the question was asked is, so if you have less than an optimal response with triple therapy, should you add a fourth drug to try to get a deeper response prior to transplant, or should you simply take those patients to transplant? And then Dr. Coleman asked what I think now is currently the longest conversation I have with transplant patients. So you have a patient, particularly one with low risk or low tumor burden disease, who achieves a complete response to 4 cycles of induction chemotherapy. And you obviously collect the cells because that's the best time to collect them. And the patients ask you, so how can you prove to me this is going to help? Because you can't demonstrate, before novel agents, only 5% of the people achieved a complete remission. So the conversation was relatively easy. You have residual disease. This residual disease is resistant to the chemotherapy we gave you. I'm going to give you high-dose melphalan, eliminate those residual clones. You'll achieve a complete remission 40% of the time. You can't have that conversation in a patient who has had a complete remission. You can have the conversation that this is the youngest you're going to be, this is the healthiest you're going to be. When the myeloma comes back, it's only going to be coming back more resistant. But you can't have the conversation that I'm going to put you in a complete remission until we have the instruments, such as polymerase chain reaction and flow cytometry, that allows us to show that we will be able to, deepen the depth of remission with high-dose melphalan. So I want to once again summarize, I think, something that is becoming a theme for us when we get called from referring physicians is, what is the optimal induction? And I think the preponderance of data for transplant-eligible patients is that bortezomib-based inductions are probably now, with 4 randomized trials, all showing that bortezomib changes the course of the disease after the transplant. Although there's never been a head-to-head comparison of bortezomib, lenalidomide, of a lenalidomide dexamethasone doublet to a bortezomib-containing triplet, I think it's reasonable to suggest that these patients should get a bortezomib-based regimen. And just start looking at the conversations we're having now, So triple therapy with bortezomib, lenalidomide, dexamethasone, followed by 2 transplants, followed by a consolidation. 76% of the patients without progression at approximately 3 years, and more than 8 out of 10 patients achieving a 90% reduction in tumor burden. So that's the bar. So as we think about how we're going to move the field forward, we already have 8 out of 10 patients with, and this is without lenalidomide, this is with thalidomide, that we have 8 out of 10 patients achieving a 90% reduction in tumor burden and 7 out of 10 not needing any further therapy for 3 years. And this seems to hold regardless of any of the risk categories. So again, as what was mentioned this morning, is that a lot of the gene expression profiling and a lot of the risk assessment data that has been done using prior therapies. And we probably have to reassess whether our current modern therapy is actually going to eliminate some of these poor prognostic features. Add to that we have carfilzomib coming up and probably becoming commercially available with known at least regimens that have been effective and have been published in the induction setting. Just want to call your attention to the carfilzomib thalidomide dexamethasone that Peter Sonneveld presented in ASH. More just to, again, allay the fears that carfilzomib does not affect stem cell mobilization. So people can be mobilized after carfilzomib. So I think the only way to answer Dr. Colesman's question about what is the role of stem cell transplant in a patient in complete remission is with a randomized trial. Now, there are currently multiple randomized trials that are going on at the time of diagnosis. So patients get diagnosed, they get randomized to early versus late stem cell transplantation. Everybody gets a standard induction. We will be able to compare the outcomes of patients who underwent transplant in complete remission versus those that were randomized to a late transplant. But just so you know, if we wanted to do the perfect trial, which is randomized patients who were in a complete remission after 4 inductions, and then randomized to early versus late transplantation, we'd probably need more than 1,000 CR patients. And if you back up to that, means you probably need more than 5,000 patients. It just becomes logistically very difficult to definitively answer that question. But at least we'll have an inkling based on the results of the French and the Dana-Farber study, and hopefully based on subset analysis of Dr. Palumbo's trial, which currently is the only trial of early versus late transplantation that has currently been reported. Again, if you look at the design of this trial, as I showed you yesterday, this is not the way we would practice in North America, and based on your responses, it's not the way that many of you are practicing in Southeast Asia. So patients will get an induction with lenalidomide dexamethasone and then either randomized to a tandem autologous transplant with melphalan at high doses, or what we will call chronic alkylator exposures with steroid and lenalidomide, and then randomized to maintenance versus no maintenance. When this was initially presented a year or 2 years ago, there was no difference amongst the groups in regards to overall response rates or progression-free survival, and as a good randomized trial, there was balance amongst both MPR and MEL200. So interesting that although the response rates are similar for MEL200 and MPR, when it was presented last year at ASH, there is now a difference in progression-free survival, which is statistically significant. 73% of patients getting a tandem auto being disease-free at 2 years versus 54% for those patients who had chronic melphalan, lenalidomide, prednisone exposure. No difference in overall survival as of yet, but I remind you that in these trials, median follow-ups of 3 years or less are not enough to show a survival benefit. So this is the take-home message. It is the first of the trials that are looking at, early versus late transplantation in the context of novel induction. It is its main pitfall is that there is no bortezomib exposure in these patients, and many of us would think that the chronic exposure of melphalan, prednisone, lenalidomide is probably a great recipe for secondary hematologic malignancies. And that's probably not the way we would want to be giving lenalidomide now that we know that there is a safety signal when it's given in the context of chronic alkylator exposure. So I presented 2 cases yesterday. One is actually a true patient of mine, and that's actually the case with the low-risk disease who achieved a complete remission after 4 cycles of bortezomib, thaldex, and an autologous transplant. The other case is, imagine if this is the same patient but now high-risk disease. Actually, my patient did have an HLA identical sibling, and she was on the lenalidomide trial and was given the option of going on lenalidomide maintenance. And at that time, she actually asked me the following questions. Well, if I don't go on lenalidomide maintenance, what are you going to do? I'd say, I follow you carefully. And what do you expect from having achieved a complete remission? What is my remission duration? And it was usually 4 years based on the data that Dr. Wang and Dr. Alexanian had on our CR patients. He said, so what are you going to do if the disease starts coming back? I said, I'd start you on lenalidomide. And her conclusion was that she was better off not going on lenalidomide maintenance. And she's been off treatment for now 6 years and she has not relapsed. So I think, as Dr. Joshua was mentioning yesterday, until we start seeing a strong survival signal, although the progression-free survival data of maintenance therapy is very strong, we need to actually make an individualized treatment decision on patients, and particularly for those who have achieved a complete remission and have low-risk disease. The other patient is actually another challenge. So you have 55-year-old, high-risk disease, does not achieve a complete remission, and you have an HLA identical sibling donor. What's the role of an allogeneic transplant? So I remind you, there's been multiple, not randomized trials, but biologically assigned trials. The French trial showed no benefit. The Italian trial showed significant survival benefit, both of them hampered by a small number of patients. So the Blood and Marrow Transplant Clinical Trials Network concluded the largest biologically assigned treatment for myeloma, looking at patients who had a frontline autologous transplant, and if they had an HLA identical donor, they would go to an auto reduced intensity allo. If they did not have an HLA identical donor, they would go through a tandem autos. This was recently published in Lancet Oncology last year with Amrita Krishnan as the first author. And you compared the standard risk patients, 436 versus 189. For both progression-free survival and overall survival, no difference for the auto versus allo. Was there a graft versus myeloma effect? And we couldn't see it. I mean, there's 46% relapse rate versus 40%. That difference obviously did not overcome, although a relatively low transplant-related mortality of 12%, but for the tandem autos, it was only 3%. So again, there may be a graft versus myeloma effect. We just still have not learned how to exploit it. Interestingly enough, of the patients who got chronic graft versus host disease, the relapse risk was actually only 15%. So we do know that there is a graft versus myeloma effect. We just haven't been able to separate it from graft versus host disease yet. So what makes the question of allogeneic transplant and frontline therapy much more difficult today is the new bar. And this is just, again, this is the IFM, so just think about the conversation that you would have had with the patient who had low-risk disease and had achieved a complete remission. Her progression-free survival with lenalidomide maintenance, having achieved a CR, is upwards 75% at 3 years, versus had she stayed on maintenance is around 50%. And that was significantly better. But once again, no survival benefit. This is the CLGB trial, which has now shown a tendency towards a survival benefit. This was a crossover design, not intentionally. That's what the DSMB required us to do. Further follow-up will be essential so that we can actually educate patients and instruct patients and counsel patients with data more than feelings. But again, in my feeling, that case number 2, high-risk disease, no CR, definitely should go on maintenance therapy. So I think the other thing that's emerging is that even after 2 autologous transplants, there may be a role for more intensive therapy, for more consolidation. And last session, you saw a little bit of Dr. Ladeto's data. This is from Dr. Calvo's data, looking at patients. This is a per-protocol analysis. So these are patients who were actually received the VTD consolidation as it was prescribed in the protocol. The major thing here is that there was a significant proportion of patients, around 66%, who actually upgraded their response. And many of these patients actually achieved PCR negativity status. And if they achieved the PCR negativity status, and I'll mind you, this is a subset of a subset of a subset, but it starts going towards that if we have adequate tools, we actually can tailor treatments to let's call truly minimal residual disease. And that will be probably the best way of reducing burden of treatment. Because I do believe, as Bob alluded to, and as many of you have alluded to, that using the total therapy approach that was pioneered at Arkansas, we are over-treating a significant amount of patients. We just don't know who those patients are. So I think this is a trial that I'm personally very proud of. This is, again, the third large North American clinical trials network looking at myeloma. It's called Stamina for Stem Cell Transplantation for Multiple Myeloma Incorporating Novel Agents, or because the principal investigators and the protocol team took 2 years to get the study up and running. So in this trial, patients who have one autologous transplant get randomized to the standard, which would be lenalidomide maintenance, versus 4 cycles of consolidation versus a tandem. And I do disagree with Bob. I don't think the question of tandem transplants has been answered. And the post hoc analysis that was done from both the Italian and the French was really not powered to answer the question. So although common knowledge is that if you don't have a good response to the first transplant, you should get a second, but if you've had a 90% reduction in tumor burden, you don't need it, that data is not there. It's never been tested. That hypothesis has never been tested in the context of a clinical trial. So Dr. Orlowski presented this, which I think is our next challenge, although in North America, the standard practice now is to collect enough cells for 2 transplants, although most patients just get 1. So what do you do with the cells that are in the freezer? And there is a significant proportion of patients who have cells in the freezer that are currently not being used. So the questions comes up is, what would you want to use those cells for? One option is you can use it in the setting of relapsed and refractory myeloma, where there is a 40% response rate, but the duration of remission is only 6 months when you do these last-ditch Hail Mary transplants. But if you look at this list of drugs that are, effective in the context of relapsed and refractory myeloma, I just want to show you bendamustine because it looks at high-dose alkylator therapies. These are one of the most active agents, and with novel therapies, many of our patients are not exposed to alkylators anymore. I'm not going to go about the vorinostat data. So I think this is the time where we really need to re-explore what is the role of a second salvage auto. This is just one of the many retrospective analyses that have been done. So look at patients who have had a 36-month remission. When they underwent a second salvage auto as consolidation of response, their remission was 30 months. And this is probably better than what we would get with any of the other salvage treatments. Even if the remissions lasted less than 2 years, the median progression-free survival after salvage auto was about a year. So I think this question about when is the best time to do a salvage auto needs to be explored. This is a trial that we're performing through the Tri-State Transplant Consortium, hopefully to be open at the third quarter of this year. This is for patients who are relapsing after lenalidomide maintenance. They will all get a pomalidomide dexamethasone reinduction, and then they'll be randomized to either get a second autologous transplant versus continued pomalidomide dexamethasone, with all patients getting pomalidomide maintenance. And we're looking at a complete response rate as the endpoint, and it's 72 patients, 36 in each arm. So I think also salvage auto is a great way to look at new drugs and new combinations in the context of maintenance and in the context of how we're going to go beyond high-dose melphalan, which has been the standard conditioning regimen for the last 20 years. This is just, the Blood and Marrow Transplant Clinical Trials Network had a meeting in November last year at Minnesota. And there was a brainstorming session about looking at what are the new ideas that could be incorporated into a frontline trial. And there were 2 themes. One theme was new conditioning regimens, and the other theme was novel maintenance therapies. And amongst those are, Bob Orlowski and Jayton Shah had looked at, were proposing an elotuzumab Revlimid maintenance, now, a monoclonal antibody with an IMiD. There was elotuzumab in the oral Millennium agent. So there are a lot of ideas. But how do we choose these ideas to move forward? I think at this moment in time, we really have more ideas than patients. So I think looking at randomized phase 2 trials as ways of picking a winner that we can move towards a more definitive trial. And this is, the populations are there, and these are people who are relapsing after primary therapy. So I want to finalize by reminding everybody that there's no doubt the myeloma therapy has changed substantially over the last 10 years. These changes have resulted in major changes in the standard of care, proteasome induction, lenalidomide maintenance, treatment of relapsed disease. But the change in the natural history that has occurred because of this has only been possible because we have supported, we have designed, we have implemented, and we have accrued to very well done prospective clinical trials, plus we've supported translational science research. Thank you very much for your attention. And I too, if you have any questions.
I'm Dr. Tabadghav from Lucknow, India. I would like to ask you, outside the trial, what is the conditioning regimen that you use for second salvage?
Unfortunately, outside of a trial, I still tell you we're doing melphalan 200, although there are at times when we're looking at a more intense regimen like busulfan and melphalan. There have been multiple retrospective analyses looking at busulfan and melphalan versus melphalan 200. The initial large series from the Spaniards showed that Bumel was no better than Mel, but it was affected by the fact that the busulfan used was oral busulfan. A recent retrospective analysis shows that IV busulfan in combination with melphalan may actually have some benefit over melphalan 200. There are currently randomized trials looking at that. If it was a board exam question, you have to answer Mel 200. That's the bottom line.
Hello. If you have a patient, can I ask a question?
Yes.
If you have a patient who had a transplant with 200 per square meter melphalan, and you follow up the patient, and during follow-up you see the paraprotein coming up, that the patients are otherwise okay, how do you intervene them?
So now this is the finding of oligoclonal reconstitution post-stem cell transplant is fairly frequent, and it's sometimes impossible to distinguish this from what could potentially be a potential relapse. The fact that with lenalidomide maintenance, 80% of the relapses are now what we call asymptomatic or chemical relapses. So we're seeing the paraprotein peak come up before we're seeing any symptoms of the disease. Makes the challenge even worse. So the question is, what do you do if you see the paraprotein peak coming up early post-transplant? The first question is it a true relapse or is it oligoclonal reconstitution? Only time will tell, and a careful look at the gel sometimes, if you see other oligoclonal peaks, you can make the distinction between, okay, this is probably oligoclonal reconstitution or a true relapse. Obviously, if the paraprotein peak continues to increase, or if there are any signs of progressive disease, then the patient has progressed, they've achieved IMWG criteria, and they should be treated. I think what we're learning is you shouldn't make a clinical decision based on one determination alone. The paraprotein peak by itself is not the criteria for relapse. You have to put everything together. And then, well, one thing is that particularly challenging for transplant centers in developing worlds and even the United States is what do you do with a patient who you send back to the community where the methods to be able to follow the disease aren't the same. And we're trying now to see if more and more if we can get people to send us blood so we can do all the assays locally and then instruct the referring physician about what to do.
Okay, last question, please.
Jeffrey from Taiwan, and I know that even after the auto transplant, the patients will eventually relapse. The problem is the tumor cells within the bone marrow. So my question is how to purge those remained tumor cells in the bone marrow. So do you think that the anti-CXCR4 or the bortezomib can do the job? Thank you.
So a couple, and I thank Dr. Jeffries for a question because it does touch to an area which I think we've also abandoned. So first is we do believe that we do cure 15% of all patients who get transplanted, so there is a cure fraction, not everybody relapses. Two, what is the role of purging? When you compare twin transplants to auto transplant, the relapse rate is less. Now, is that due to the fact that there is a syngeneic graft versus myeloma effect that is induced by twin cells? And actually, it is known that the cells of two twins are not identical after the age of 60 because there are epigenetic changes that actually produce proteins that are different and can serve as targets for graft versus tumor effects. But I do think it speaks to that there may be a role for purging. And now that we're getting patients to 60 and 70% complete remission rates, I think that purging needs to be re-explored. Dr. Elizabeth Schwal at MD Anderson did a clinical trial looking at purging with bortezomib and Rituxan, and it was very effective in cleaning the marrow of clonal myeloma cells while preserving CD34. This is now trying to be taken into the clinic. So I think purging is going to be re-explored at this time. Which purging technique, I can't. I don't think it's going to be CD34 selection.
Okay, thank you very much.